Good morning. Good morning to all.
Good morning.
I'm just waiting for a few more.
Good morning.
Good morning, Tiffany. How are you?
I'm all right.
Good.
Just a little tired.
Yes, I hear you.
So were there multiple um classes this morning for the same subject, or I'm confused because we were just in somebody else's. Actually, so was Mickey look at it?
Yeah, Professor Kershaw teaches at the same time as me on Friday morning, but if you're from Monday, which you are, I was just assuming you'd be coming to my class.
Okay.
But either
Okay,
one,
because me and Crystal was in that one, but I told Crystal to come out of hers and to come over to yours.
yeah. Yeah, the schedule I gave you, there were two classes to attend this morning. Most decided they were coming to me. So that's probably what's going on. I'm glad you're here. Did Professor Kershaw tell you to come into my class?
She was saying that we was in the wrong one or something, so I just left, and then I contacted a classmate, and they told me that you were on, so
Yeah.
I
Yeah, that
just
was on
switched
the
over.
schedule. I just assumed that most people said they were coming to my Friday class instead of Wednesday or Friday. I have a couple of people attending tonight with Professor Ford. So yeah, I'm glad everybody's here. I think I've got almost everybody here. Just waiting on one student, two students from my Monday class. So anyway, we'll get going. So, how is everybody? Friday, week 9. This is the last. Oh, this is the last class of content, right? After today, you go into your exam next week, and then straight up into HESI. So let's review a couple of things. Okay. So this week by Sunday, your HESI prep is due. I've had a lot of people turn them in, and I've been trying to grade them as they come in. I think I was up to date as of last night. So anything that came in overnight, I haven't graded. Um, so you got your HESI prep. You also have exam reviews this week. I did mine on Wednesday morning. I only had two people, which it is what it is. I wish I would like to have more, but I think I've already sent the recording, right?
Mhm.
You guys have the recording. Okay. Um, Professor Ford did hers yesterday or last night. I had probably 5 or 6 students there. So I do have the recording as of this morning. And so after class, I'll send you her recording. Okay, so you'll have that. And then I believe that Professor Kershaw changed hers. I sent you an announcement about that to this afternoon. Okay, so I should have her recording hopefully tonight. Um, and then that will be your 3 recordings that you'll have for exam 3. Okay, so So we've got the reviews this week, your HESI prep this week, you have your case study, and you have an NCLEX. Right? Okay. And then obviously next week we do the exam at the class time, same time as your class. So you'll be doing, well, some of you will be doing it Monday because you're in this class for a makeup from Monday. And then the rest of you, if this is your section, you'll be doing it Friday. And then next week, along with the exam, you have your vulnerable populations paper due next Sunday, right? And then next week, there's also some HESI reviews. Okay, there's 3 different HESI reviews. So if you can
Sorry,
try
is the vulnerable population thing a paper or a PowerPoint?
PowerPoint, sorry, PowerPoint. And make sure, I have gotten a couple in already. Make sure that this is a population in your community, right? So let's say you're doing teen pregnancy. I mean, I've just seen a couple that don't have the specific county or zip code. Make sure if you're doing homelessness, you're doing your research on the homelessness in your zip code, not, in the United States, a certain percentage is homeless. Here's what this has to be. It's the rubric is specific to your community, not a general national statistics. Does that make sense? It's to your community. So, so week 10, vulnerable populations, HESI reviews and your exam. And then week 11, that's the other thing that I will get to you guys. I had an email last night that all of the, have you guys got an email from campus about when your HESIs are scheduled for? Yes, Whitney's shaking her head. Amelia's shaking her head.
Yeah, the
So-
registrations are up too with the dates on them.
They are. Okay. All right, so that's a Scranton. Okay, what about Cincinnati students?
As
Uh,
of yesterday, they were not in. We couldn't even sign up for it.
who's talking?
Tamara.
Oh, okay.
Wait a minute. Correct
and-
me, everybody from Cincinnati. Was it in there? Because it was one that we couldn't get into, but I couldn't remember if it was community or med surge.
That was mid-surge.
Okay, then I'm wrong. We did get into it.
So you did,
I think
okay.
yours had 2 times for it though. Was
Okay.
hers with the morning and evening? And we were wondering if we could do the 4 o'clock.
You'll have to definitely check with your campus on that.
Okay.
I don't have anything to do with scheduling. What I do is try and provide you the schedule that I have. So who else do I have? Columbus students. Do you guys know when you're taking your exam?
No, not yet.
Not
I
yet.
just heard about it, but this one was very, very.
Okay.
No.
So what I'm gonna do later, let's see. I need to post Ford's review, and then I'm gonna do your HESI schedule. I have a spreadsheet in which I can go in and look at the master schedule of all the campuses. I'll go in and fill that in today because I was told last night in an email that they've all been scheduled. HESI schedule.
Hey, Miss Marvel, I just wanted to let you know that I'm in Miss
Hispanic
Kershaw
family.
class.
From mom,
I didn't know you was
from
coming on
dad,
today.
2 children.
Yeah. Okay. Hey,
Your
Crystal.
mom has bruises on her arm
Right.
and her face, and the children are standing.
Hello? All right. Okay, HESI. Well, I mean, if you want, we can, hang on a second. Let's see. Let's see. Um, Hang tight. Okay. So let's look. What campuses, hang on. What campuses still need to know when your schedule is? Columbus?
Yeah.
Okay, let's look at Columbus. What am I doing here? Okay. Columbus. Columbus. Okay. You guys are going to be right here Friday the 22nd, 9 a.m. and 7:30. What other campuses do you need?
Can you look for Norfolk, Virginia?
Norfolk, you bet. There you go. So PNR 208, 9 a.m. on Friday. Okay. Any other campuses?
Richmond.
Richmond. There we are. 208, right here, 9 a.m. on Wednesday,
The 20th.
20th.
I got a question.
Anybody
Is
else?
it listed? Yes, I have a question. Is it listed for all of the courses for that term?
Mhm.
Like I see you have a 205. Is that
This is the
leadership?
master schedule.
Can you go back to Columbus real quick? Because there's another class that they said will be determined, and I wanted to
What
see what
class are
day
you
did they
looking for?
205.
Right here, PNR 205, Tuesday at 9 a.m.
So then 200 is
What?
at 9 o'clock? No, I'm trying to see what all these classes. That's mental health.
Well, this is the big master schedule. I shouldn't even have this pulled up, but I'm just
I
trying
know,
to get
but
what do
yeah,
you
no, that makes sense though. It makes sense. So I'm taking one on Monday, one on Tuesday, and one on Friday. Okay.
okay?
Thank you.
Okay. And you should be getting notification from your campuses to register, like Matthew said. Sounds like you already have. Yeah, just be watching for those emails. I simply like to provide you a spreadsheet with the days and times. So you have a heads up. Okay. Questions about HESI? I sent you in your weekend announcement. I did the roadmap announcement for the next 4 weeks, 9, 10, 11, 12, and put specific dates in there. Couple things to point out. Please pull up on your desktop that announcement about remediation guidelines. It hasn't changed, but I just want you guys to be aware, right? About the number of hours that you need to spend on remediation depending on what your score is. Everybody knows what I'm talking about, right? You've been doing this in prior semesters. Okay, so I have posted those in the announcement. I sent the study guide, the concept guide for exam 3. So what I'd like to do today, when we get finished just checking in, is I'd like to spend a little bit of time on the content from week 9, which is human abuse and violence, and then we'll talk a little bit we'll kind of wind everything down with culture again, cultural competency. And then I'd like to spend some time reviewing the concept guide with you, the exam guide. Okay. I know a lot of people can't make it to reviews. So I'd like to at least review that with you guys. So that's what I plan on doing today. Would that be helpful?
Yes.
Okay. All right.
Yes.
Okay. What else did I want to mention? Yeah, this is it. This is kind of the last week we'll all be together as a class. Next week is an exam, and so overall, how have you enjoyed the class? Like
It's
to get
been
some
awesome.
like to get some feedback.
I've learned a lot.
Have you?
Yes, ma'am.
Good.
It made me read.
Okay.
And I just each time, it gets better and better. So
Mhm. Were the
um,
readings helpful?
yes, ma'am. Yes,
Yeah.
ma'am, definitely.
Yeah,
Yes,
the three books that we use in this class are really we used to use a couple of terms ago the book that the RN program uses, the foundations. And since we switched over to using three books that you already have, it's really the content coming out of those books has been really helpful and at least for me preparing my lectures, really good information. Much more enjoy that than the foundations. So, okay, thanks for that feedback. Anybody else have any feedback?
yes, ma'am.
I have improved in my test taking skills. I have
Good.
like, 'cause you got to throw away information that you think you know or you previously learned and just focus
Right.
on the information given at
Okay,
this class. Yeah.
great.
I agree
Great.
with that as far as the test taking skills.
I did too.
Great.
I do, Miss Savage. Mhm.
Super. I mean, the community's different, right? It's not like your PEDS exam and your med surg exam, right?
That's right.
Yeah. So when we started in week one, we talked about what community nursing was all about. Do you have a better understanding about what community nursing is about now?
Yes, ma'am, I definitely do.
And how many different kinds of nursing roles and different way we look at ADPI, how that's all involved?
Right.
Yeah.
It's helped me a lot.
And some of you may never work, like I think I probably said this in week one, some of you may have never work in the community in your career, but you will interact with healthcare workers in the community, right? Okay. When your, I'll send you an email about this, but when your course evaluation comes up in your shell in the next couple of weeks, take the time, just a few minutes to fill it out. It really, really helps me. Okay, it helps me in preparing for my next term. I really like to get feedback, positive, constructive, doesn't matter. I take everything into account. But I'm always striving to improve the way I present information or the way I do lectures or the way I do reviews or whatever. So I'll send a reminder email, but please take 5 minutes and just do that. That would really help me. So, all right, let's jump into talking about week 9 content. And then we'll jump to the guide, the concept guide. Has everybody opened the concept? Well, we'll talk about that in a minute. Okay. All righty. Can everybody see the screen? Okay, let's start with the real tough topic, human abuse and violence. What kinds of things do you think about when you're forced to think about human abuse and violence? Let's start with violence. What kinds of violence are we talking
Domestic
about?
violence.
Physical, emotional.
Mhm.
I mean, emotional violence, is that a thing?
Mm-hmm. Sure. Let's talk about violence. What kinds of violence will we see in the community? We will see murder. We will see assault. We'll see battery. Well, even suicide is a form of violence, right? Violence against yourself. We see individual violence, person on person, family violence, lots of different kinds of family violence, right? domestic violence, child abuse, child neglect, intimate partner. I see a lot of gang violence in cities. And it's just seems like things are getting worse. Right? What about human abuse, child abuse, spousal abuse, human trafficking? Right? Lots and lots of different kinds of human abuse and violence. We know that violence is a maladaptive coping mechanism, obviously. Right? We know that violence is somewhat common in vulnerable populations, just as substance abuse is. And maybe it's a means of regaining control that you've lost. Okay? It is violence, human abuse is predictable and thus preventable if we look at both victims and perpetrators. And in the course of your nursing career, you're going to be caring for clients in any setting, whether it's home, urgent care, long-term care, wherever you work. You're going to be caring for clients that may be perpetrators of violence, whatever that violence is. They may be victims of that violence, or they may have witnessed the violence. Okay? People who become involved in violence typically have had previous exposure to some sort of violence. For example, abusers were often beaten when they were kids, or they witnessed siblings or parents being beaten. And they learn that violence is a way to manage conflict. We know that health disparities such as living in poverty, not having good access to health care, living in crowded conditions, disparities, right? High levels of violence are tied to health disparities and adverse health outcomes. Okay, for example, think about chronic stress. Chronic stress can cause physiological conditions, maybe obesity, diabetes, hypertension. Let's say you're unemployed, or you're getting laid off, or you have to file for bankruptcy for whatever reason. Those are disparities, and those are going to increase the risk of violence. Look at all the workplace violence events we've seen in the past several years. We know that, you should all know that we are nurses, we are mandatory reporters, right? We're mandatory reporters of violence against children and the elders. But we do not report violence against adults without their permission. You guys know that, right?
Right.
So if you're the reporter, it doesn't matter where you're seeing or witnessing the violence. Could be in the school setting, could be in the home setting, could be the neighbor, could be the grocery store, right? It
Hey, I'm
doesn't.
sorry, I have a question really quick. I thought maybe I misheard you. Did you say that if you're that we can't report abuse against an adult without their permission?
Mhm,
Okay,
mhm.
that's
We-
interesting.
We want them to self-report. That's
Okay.
we give them the opportunity to self-report first.
Okay.
And then if
So,
they do,
But if they don't, like that, is that like, do you not, like, I'm confused a little bit then. So then if they don't want to self-report,
then you report.
okay.
But we
Because I
give
was like,
them
do
the
you just,
opportunity, I'm
do you
sorry.
turn a blind eye because they
No,
don't want to
we give them
report?
the opportunity by talking with them, trying to
Okay,
encourage them to
that makes sense.
self-report. And if they don't, but with kids and elderly, we don't give that option,
Right, okay.
right? Okay, sorry about that. Yeah,
That's okay. I understand now. Thank you.
yeah. Um, there's a difference between physical neglect and emotional neglect. Physical neglect is failure to provide adequate food, shelter, clothing, hygiene, necessary medical care. That's physical. Okay. Emotional is more of the nurturing, acceptance, being involved in health development, growth and development. Does that make sense? There's a difference.
Yeah.
Okay. We know that kids who are exposed to violence, whether they're victims or witnesses, are high risk for mental disorders. Okay. They're also high risk for self-harm, substance abuse, and actual suicide. Right? I saw this a lot in the schools. Okay, when I had kids from preschool all the way up to high school. Okay, this is right here. Children exposed to violence are at high risk for lots of things. This was very prevalent in the high school kids and middle kids to some extent, but a lot in the high school population. We know that abuse is about power and control, and all of these acts of violence are methods of control. Family violence is usually between the most powerful and the least powerful. Right? Family violence can be perpetuated as a cycle as kids are growing up, and they see violence used as a method to control the kids, control the mom, control the dad, whoever is in that perpetrator role. Right? And we know that abused kids are more likely to perpetuate violence or tolerate violence in their own relationships as adults. Did a lot of work in the high school setting with dating. Your dating and abuse during dating, and a lot of these high school girls didn't really have an understanding, of the increased in risks of emotional abuse, physical abuse, as they start to get into dating. What to look for, what are the risk signs? Okay. Think about families living in poverty or having economic issues, trying to deal with a crisis, maybe unplanned pregnancy, unemployment, marital strain, cheating. Those are all risk factors for potential violence. Social isolation contributes to violence with reduced social support. If the family goes into crisis and they have very little social support, it's going to be hard for them to cope with all of that. We saw this post-COVID when kids started returning to school that had been isolated for a long time. Another type of violence that we need to be very aware of is elder abuse. Elder abuse is a kind of family violence. And that could be physical, mental, emotional, financial, right? We know that abuse is about power and control. And that includes emotional abuse. And so in our, as we move forward in your profession, you're going to be seeing kids, how they're affected by violence, elderly, how they're affected by violence, and you have to be able to recognize the potential symptoms of abuse, neglect, potential violence towards these populations. So for kids, prone to more frequent headaches, stomach aches, bedwetting, anxiety, depression, withdrawn behavior, inappropriate sexual behavior, or knowledge. You know, is a 5-year-old supposed to know about whatever? Precocious younger girls, menstrual disorders. We saw this all the time in the schools. That was where a lot of this came out. A lot of this, saw a lot over 22 years. So we have to be able to, in your readings, there's some good charts about what are the signs of child abuse? What are the signs of child neglect? What are the signs of elder abuse, elder neglect? Have a look at those. We have to be able to recognize those, both in our workplace and in the community. Another population is abused women. Okay, they're also prone to chronic headaches, palpitations, sleep and appetite disturbances, sexual dysfunction. I'm just reading from our notes here. Irritable bowel syndrome, urinary frequency urgency, recurrent vaginal infections. They may experience more miscarriages, have preterm births, or have low birth weight infants. And we do know that abuse generally escalates during pregnancy. So go back to that teen who's pregnant, very vulnerable already. The risk of violence in teen pregnancies is very high. One of the top risk factors, I want to talk about intimate partner homicide. Okay, IPH. One of the top risk factors for intimate partner homicide is a previous domestic violence incident. Other risk factors that have to do with an intimate partner homicide are access to guns, estrangement, threats to kill or threats with a weapon. Maybe they've had incidents prior of strangulation, non-fatal strangulation. Stepkids in the home if the victim is a female. And then elderly, let's talk about the elderly for a little bit. They're at risk for really any kind of violence, physical, emotional, financial, as well as neglect. Some examples of that, emotional abuse may include behaviors to try and demean them or attack their self-esteem, maybe name calling, trying to scare them, embarrassing them, destroying their property, not letting them see family or friends. We know that neglect occurs when the basic needs of food, housing, clothing, medical care are not met. Maybe they feel like they're going to be abandoned and that nobody's going to be around to care for them. And what if we've heard those horror stories? What about if people take over their finances and they steal money or spend their savings? Right? We hear those horror stories too. Suicide. Self-directed violence against yourself is the second leading cause of death in young adults ages 10 to 34. one of the leading causes for suicide is depression. Okay, other risk factors, mental disorders, substance abuse disorders. Okay, but depression, mental disorders, substance abuse disorders are primary risk factors. Some other risk factors, maybe a prior suicide attempt, family history of suicide, mental disorder, firearms in the home, incarceration, and maybe being exposed to the suicidal behavior of others. And then it's pretty well known fact that kids who threaten to harm others or who abuse animals are more likely to hurt others than themselves. Right? Does that make sense?
Yep.
Some of the well, let's talk about, let's say you're in the schools and you're working with the kids. What are some, or even the parents, what are some primary prevention activities that we can do in the schools to help reduce violence, reduce abuse, reduce bullying, harassing? What are some of the things we can do, say, with the school age kids? What do you think? What would you do working with parents? Maybe do
Support groups.
support groups, maybe how to parent, how to balance work and family and school,
Mm-hmm.
how to help the parents have better coping strategies.
Yeah.
What else? Maybe work with the kids on how to control their emotions, have good coping skills, maybe anger management programs,
Mm-hmm.
identify the families at risk, right? Work with them.
Mm-hmm.
What about the parents that don't really have any support? You know, maybe help them with some resources in the community that might help them, whether maybe a religious leader or faith leader.
Yes.
Parents with a really low social support network have a tendency towards depression. They have multiple stress factors. Maybe they have a history of abuse and are at risk for abusing their own kids. Maybe they were abused. Now they're at risk of abusing their own kids. It's really it's a cycle that I just want to get the whole, it's a cycle of perpetual abuse, violence. What experiences do you have? I'd like to talk about elder abuse because that's pretty big. In your workplaces, do you have examples of elder abuse or what you're looking for when if you're working with the elderly, what you're looking for as you care for them?
A lot of things I saw during rotation was like the neglect. You see a lot of these elderly patients with their briefs that are still sitting, and we really don't know how long they've been sitting like that for, but the bed sores, and you can tell that they're just not being taken care of properly.
Mhm. Anybody else work with the elderly population? And this
I
is the
see
other,
how some people, sorry, I see how some like my clients respond to certain staff because like the way they talk to them, you can just tell by the way they talk to them and the way they respond. They don't really care for that individual.
Mhm. Yeah, we need to really be keen in our assessment skills about what's going on when we're working with at-risk populations, and the elderly certainly is an at-risk population. So, yeah, I know this subject is kind of, it's kind of hard, but it really is. Violence and abuse is really all around us, right?
Right.
It really is. Let's talk about, let's end our content with culture. I know I've been talking about culture the entire, oh, I probably didn't share that, so hang on. Let's talk about culture again. What have you learned over the last 9 weeks about the importance of working with different cultures, taking care of different cultures, having teammates of different cultures, having family members of different patients that have different cultures?
You
Give
want
me
to
what
gain
you've
their
learned.
Just to be
trust
mindful.
and learn how to learn their cultures and their beliefs so that you don't like violate their culture.
Mhm. What else?
Culture, different cultures have different perceptions on health and illness.
Mhm.
Like one culture doesn't like eye contact. I think that's what
Mhm.
Native Americans or something.
Mhm. Mhm. What else have you learned about culture? So, as a recap, culture is everything we believe to be true about the entire world, right? Culture, we're talking about your own culture. Okay, it's a set of beliefs, values, assumptions about life that we pick up through our socialization in childhood. We belong to a certain culture, right? Different ethnic groups may have cultural similarities, but we're all unique because we're different. We grew up differently, right? Culture encompasses a wide range, like Whitney just said, wide range of behaviors that are different. Cultures have different perspectives about language, touch, personal space, body language, perceptions of health and illness, but also family structure. Family structure influences culture, childbearing practices, time perception. Remember, we talked about some cultures are past oriented, some are present, some are future. Right? So, as nurses, we must approach each patient completely unique and learn how to look at their culture through their eyes. And if you don't know, ask. We also have to do our own self-check, our own self-assessment, that our culture, just because we have different cultural beliefs than our patient, that doesn't mean that ours is superior to theirs. And I have witnessed that's where a lot of the breakdown happens. People trying to impose their own cultural beliefs or values on others. You can't be judgmental. You can't stereotype. And that's why we've said throughout this class that really in community nursing, well, in nursing in general, it starts with trust. It starts with establishing a positive relationship. Like, I'm not sure, I think it might have been Tiffany who said that she observes patients treating staff members in different ways, right? Maybe a patient or client has had a poor first experience or has a poor relationship with a staff member because that staff member is not either recognizing what the patient needs, recognizing their cultural beliefs, or wanting them to be autonomous and participating in their care. Okay. We have to understand our own cultural beliefs. We can't impose them on others. Okay? So, one of the things, let's say you're in a community that has a lot of non-English speaking. Okay? Community nursing is all about partnerships. Okay? It's about pulling your resources together. It's a team approach. We talked about this early in the term. You're a nurse going into a community nursing role in a community that you know nothing about. You're asked to do your community assessment. And you stand there and say, where do I start? Well, maybe you start with pulling out the community leaders, the community resources that you have. Maybe you would want to, maybe your trusted community leaders are your religious leaders or law enforcement or education leadership, mental health resources. You have to pull in everybody. Community nursing is a team approach. Lots of different people involved in planning for the future success of your community. Let's say it's a community that has a high crime rate. You want to be talking to law enforcement. Let's say it's a community of non-English speaking. Well, let's reach out to whoever can help us. Maybe there's some religious groups or religious leaders that have resources in different languages and interpreters and translators. And what if you have a community that nobody finishes school, the dropout rates are high? Well, let's partner with our education leaders and figure out a plan to improve those numbers. That's because communities are so diverse now. There is no chance you're not going to avoid working with groups of people who have significantly different cultures and languages than you do. This is not going to happen. It's here. It's here to stay. And we need to do our best to be as culturally aware, have cultural knowledge, and be culturally competent. Okay? So trusted community leaders can help the community nurse as she enters into the community as a new person. They could help develop a plan that's best suited for whatever their actual needs are, perceived needs. Right? Community leaders know best. Right? So whether your community leader is religious, education, mental health resources, maybe food banks, all these different resources, the community leaders know. Okay, they know how to communicate and work with their population in a culturally appropriate manner. Okay, maintain an open and objective attitude towards individuals and their cultures. Avoid seeing all individuals as alike. Be aware of your own cultural beliefs and avoid projecting our beliefs onto others. Being culturally aware is a self-examination in the exploration of our own feelings, our own biases, judgments, biases, prejudices. Right? Nurses who do lack cultural knowledge and competence, it's going to be very difficult. Okay? It's going to be very difficult. And then lastly, to develop, finally, cultural competence. I mean, I'm still working on cultural competence in my nursing practice after 40 years. To develop cultural competence, a few things need to happen. Be sensitive to cultural implications during each nursing encounter or each encounter. Avoid stereotyping based on race, ethnicity. Ask questions to stimulate your learning about the client's culture. Don't make assumptions about nonverbal cues. like the Native Americans don't like eye contact. They look at the ground. Okay, so avoid making assumptions about those kind of cues from clients from unfamiliar cultures. Do your research, make ongoing discoveries about various cultures, and make that a priority in your practice. Okay, we talked about not thinking that your culture is better than somebody else's. And then always try and find interpreters. Try and find translators to help with, and when you've had exam questions in the past about this, you know, if they don't speak English, you've got to try and find a way to communicate with them in their primary language, right?
And with the interpreters, is because I remember it was a question on Zam. I don't know if I got it right. It was a question about having a receptionist that could speak two languages or go finding an interpreter.
Mhm.
So is the receptionist an interpreter because she speaks two languages, or they need to be
Well,
trained?
here's what got for the people that I reviewed that question with. Here was the part of that question that a couple of people missed out on. That question did not say that the receptionist, the triage person, was Spanish speaking. That's where people got caught up. They assumed that she was Spanish speaking. That's why one of the answers was, well, have the triage person do the interpreting. Well, that wasn't the right answer. The right answer was there was an assumption made that she was Spanish speaking. There wasn't. It wasn't a trick question. It was, what is she supposed to do if the person says no habla English, I need an interpreter? Well, the simple answer was find an interpreter. That was the correct answer, right? Now, if that person can translate, that's great. That's great. But if they can't, that was the question, what do they do? You've got to find an interpreter, another employee who speaks their language, but it's going to be impossible to communicate with them. Okay? So that's my final push, cultural competence. In this day and age, with all the cultures we are working with, whether it be in our workplace, our schools, our neighborhoods, our social settings, we're going to be exposed to and engaging with lots of different cultures. And it's pretty cool to learn about different cultures and learn what people's values and beliefs are. It's been, for me, over the course of my 40 years, it's been an incredible learning experience. So embrace it. Okay? Any questions about those two? The human abuse and violence is a hard one. It's a hard one. But as nurses, we're going to be intimately involved in working with clients that are victims, perpetrators, witnesses, from kids all the way up to the elderly. And then cultural competence is my final mantra. I would have not thought about this 30, 40 years ago, but as I've progressed through my career, it has been abundantly clear of how I was going to have to expand my knowledge of all the different cultures that I've worked with. So, okay, any questions about that? We're going to move on to, I want to review the concept guide with you. Has everybody, you guys want to pull that up? Take a minute to pull that up. It was in your, no, it wasn't in your announcement. I sent it, I think, on Sunday. Okay, so let's pull that document up. It looks like this. Okay. Everybody have it? I've tried to make it a little bit easier for you by copying and pasting the readings, where the readings are coming from. Okay, so you've got week 7. This is week 7, week 8, and week 9. Okay. It's the same type of exam. 50 questions, 5 math questions, multiple choice, select all that apply, math problems, positive STEM questions, negative STEM questions. What do we mean by a negative STEM question? What's a negative STEM question? Somebody give me an example.
Further instruction is required.
Say that again. I only caught half of what you said.
Further
Matthew.
instruction is required if you're teaching somebody.
Mhm. Yep. So give me an example. Give me a question, Matthew.
So the nurse observes a UAP performing care on a client. What intervention requires immediate intervention?
What does she say? What does she do that requires when we-
She
Right.
leaves the client, puts the side rails down and leaves the client to go get
Yeah.
something.
Exactly. Does everybody understand that? That's a negative STEM question. What did somebody say or do that is either incorrect or requires more education, re-education? You're observing the nurse doing discharge teaching with the client with a stroke. What does she say that would require more re-education? So she's essentially said something to the client that's not correct. Right?
Right.
Does everybody get that? Okay, because there are negative STEM questions in this exam. They're in all the exams.
Yes.
Okay. Anybody that's having issues with math at this point, okay, please, please, I implore you to go back. These are simple math questions. You got to know these math questions. I implore you to go back to week 1 to the announcement I sent about math resources. That's the subject line, math resources. This is a simple tutorial that Professor Bogart from Pediatrics did. And it goes through all the simple formulas that are in these exams. There's only a couple of them. Okay, so I'd highly encourage you to go back and review that. It has some handouts with it that are nice little cheat sheets. Okay, so I implore you to do that. Okay, there's no math on the HESI. So this is really the last exam with math questions, but you really need to know how to do these formulas and set up these, it's very simple, set up these simple equations. Okay, the study guide that I put together has come from, as the other two have, the readings, which I have found extremely helpful. And the readings has helped me put together my weekly notes that I send to you. I often wonder if I just hold on to these notes and use them as, my lecture material, but I found that sending the notes along that I'm going to use gives you the opportunity to review them ahead of time if you do, and kind of follow along as we go and take notes on those. So this concept guide is put together from the readings, from the notes, the weekly notes that I've put together after going through the readings. And the weekly notes are really kind of the big picture. It's kind of the attention to detail. What do you need to know to understand this concept? Now, when I put together the concept guide, I really try and I'm hoping that in the lecture of giving you that you've learned the concept as a whole. But for the exams, we don't need to know everything about the concept, right? We need to pull out the important parts, kind of the bullet points, to help you understand that concept. And so what the concept guide is what you're expected to know that you're going to be tested on. Does that make sense? So if you put together, you know, 12 pages of notes for 3 weeks, 4 pages from week 7, 4 for week 8, 4 week 9, I've combined those 12 pages into what? 4 pages? Does that make sense?
Yep.
So as you're getting going studying for the exam, and I've probably already said this before, start with this concept guide. Okay, it lists I think there's 5, 6, 7, maybe 7 or 8 concepts in this. Start with reviewing this guide. If you're not getting it, or you would like to expand your knowledge more, go back to the readings or go back to your notes. Okay. And then if you're still not getting it after reviewing your notes and readings, then set up a time with me prior to the exam to go through whatever concepts you're struggling with. All right. That's how I would attack it. Okay. So in week 7, this is what I want you to know about infectious disease and prevention control. Okay. You need to know that there are requirements for reporting. You need to know about the epidemiological triangle. Remember, your agent is whatever is causing the illness, COVID, flu, strep, whatever. Host is us, right? What impacts us to determine maybe how sick we're going to get? Have we had a vaccine? Are we unhealthy? Do we have comorbidities? What's going to affect how we're going to react to this agent? In the environment, same thing. What's going on in the environment that may make it worse, may make it better. I don't know. Let's say the environment is very hot or very cold or very crowded. How is that going to affect how you, the host, is going to react to the illness or the microbe or the bacteria or the virus? So have an understanding, be able to, go through a scenario or be given a scenario, and are we talking about the agent, the host, or the environment? Okay. How do we handle airborne? Right? Proper hand and hygiene is the single most important aspect of medical asepsis and infection control. N95s for airborne. Right? Let's say we're talking about TB, private rooms, negative pressure, if airborne. What's contact precautions? Right here. Contact precautions, wearing gloves. Universal precautions, wear gloves. Okay. What's hepatitis? Viral, bacterial, it's viral. You have to have an understanding of, just a basic understanding of what's the difference between Hep A, B, and C. And I've given you a small scenario, a small description of each of them. Okay, you're going to get asked, given a scenario, remember, clinically focused, that a patient presents with this. What kind of hepatitis is it? Okay, smallpox. What does smallpox start with? Is it contagious? And we talked
Yes.
about this in class. Yeah, it is contagious. The rash starts as small red spots on the tongue or in the mouth. But the one place it does spread to that no other infectious diseases do is the palms of the hands and the soles of the feet. Remember we talked about this in class. How do you determine the difference between, say, chicken pox and smallpox? Palms of the hands, soles of the feet. Okay. I'm just reviewing this quickly. You're going through the whole guide. Okay. What about, we talked about these particularly not common, but these infectious diseases, HIV, TB, STDs. Okay, what do we want to know about HIV testing? Let's say you have a needle stick and you are tested today. Then what? We want them to come back in 3 months to be tested, right? Why? HIV right here. HIV testing is antibody HIV testing is antibody testing and can cause false negatives up to 3 months. Testing should be repeated in 3 months. Think about correctional facilities with HIV. People with HIV are already immunocompromised, right? They're susceptible to infection, right? So infections in a correctional facilities, one of the common infections is TB. Got to make sure that these HIV infected persons, if they're going to be incarcerated, they need to be deemed non-infectious before they enter the facility. Here's what I want you to know about TB. What is it? 95% of it becomes latent. How do you screen? What if it's positive? What if your skin test is positive? A couple more things about TB there. STDs, here's the ones I want you to know about. Chlamydia, gonorrhea, syphilis. Okay. Bacterial or viral? Bacterial is treated with antibiotics, viral is not. Particularly in syphilis, the reason why it's listed here, and there's lots of STDs, but syphilis is specifically mentioned because one of the things that we work with in the community is pregnancy. Okay, if syphilis is not treated, okay, in pregnancy, it can be very detrimental to the baby, right? And syphilis can be transmitted transplacentally. Few things to know about herpes and genital herpes. Okay, so have a look at that. And then the last one under that was HPV. How do you get it? How is it spread? Has a vaccine? Then the next concept was bioterrorism and disaster. There are disasters we know are man-made or human or natural or man-made. Be able to identify which one is which. Okay. If you're the nurse working in the community and a disaster has happened, how do we educate the family on when water is considered safe to drink? And here's how. Boiling 3 to 5 minutes, treating with 1 ml of bleach per gallon, letting it stand for 30 minutes. And then some examples of if a chemical spill has occurred, what do? We need to use tongs. What if it's kind of a mustard gas disaster? Well, how is that going to affect people? Eye, skin, and respiratory. What about a sarin gas? Severe respiratory for sarin. And then down here, your blood agents. An example is cyanide, skin and respiratory. So those are the few agents I want you to know about. Again, I'm trying to kind of hone it all in now. And then week 8 concepts last week, we did home care, community resources, case management, and care of complex, chronically ill illnesses in the community. What's home health? In the home and individualized, right? We're taking care of individual clients. Okay. So we talk about why the assessment phase in the home health setting is longer and more involved. Well, In home health, we are guests in people's homes. We don't just walk in and start walking room to room, looking, doing our environmental or safety assessment, right? We don't do that. We don't just walk in there and open doors. Oh, yeah, we got to move this rug. It's nonstick. And, let me check the refrigerator for expired food. No, no. Home health is about establishing a relationship. We are their guest. Okay? We are trying to develop a relationship that's going to maybe be long term. Meet the family, get to know the family. Can't just go in there like a bull in a china closet. Okay? And so the other thing about home health, though, it's always revealed that the home health visit is the most important kind of visit. When we do a home health visit, we can do lots of different assessments. We can do safety assessments, risk for fall assessments, environmental assessments, family assessments. We can look at the whole picture, even though we may be in there to change a dressing or give an IV. We have the opportunity in somebody's home to do all different kinds of assessment. Okay, do they have the proper equipment? Do they have the right supplies? Okay. Yes, we're focused on individualized care for the client, but if there's family involved, they must also be included in the plan of care. Okay. The Omaha system. Omaha system we talked about this in class, was a documentation system developed decades ago by the visiting nurses. Right? It was a system that was a system that was put together to organize, sort, and document data. And because home health can be so involved, everybody can see what's going on. The physical therapist writes a note, everybody can see it. Occupational writes a note, doctor writes a note. That's the whole purpose of the Omaha system, and it's still in place. Coordinating documentation and coordinating care. Home health can be really confusing. A lot of case management goes on in home health. Okay, because home health, a lot of times we're working with the most chronic, complex kinds of conditions that require lots of resources. And that's where case management can help. So no, you can go through the rest of that. Community resources, that's just a given. That's part of your role as a community nurse, right? Each client you're going to see is probably going to need different resources. So one of the things that we need to be educated and aware of are what is in our community. What resources do we have for really any kind of issue? Okay, it's to help. I mean, home care is all about trying to get back to being self-sufficient, independent. What community resources can we provide that client that may help them do that? Right? Health departments can help. Nonprofit organizations, volunteer organizations, Meals on Wheels, Red Cross, clothing, food banks, pregnancy centers, domestic violence shelters. Think of all the resources just driving around your community. What do you see? You see lots of things in your community. Well, this is what the community nurse needs to know about and is able to refer him or her patients to these resources. We talked about this just a bit ago. What are the first steps of working with a large immigrant community that doesn't speak your language? Seeking out your leaders, seeking out your community leaders, asking them for help. Okay. And then case management. Case management, you're coordinating the care, coordinating the resources, One of the things to remember about case management is it's not for everybody. We don't have enough case managers to case manage every patient. I use the example of, let's say your client has had a triple bypass, cardiac, and they're getting ready to be discharged home. Okay, let's say they're all set up for cardiac rehab. They have family at home that can cook and clean and take them there, and it's all organized. They don't need a case manager. Let's say you have the same patient that's going home alone. Okay, they don't have the resources to get them there. They don't have anybody that can call if there's a problem. Those are the kinds of clients that might be thought to be case managed. All right, high cost chronic diseases that need a lot of coordination of services. Those are typically the clients that are case managed. And then I do want you to know, you're going to get is given a scenario, what kind of communication would best work? Okay, what's the difference between collaboration, assertiveness, cooperation, and compromising? They all sound the same. And they're all kind of in the same family. At least the 3 C's are. But they require different outcomes. And then to work in case management, there's a lot that needs to happen. You need to have the knowledge, the skills, community resources, financing methods. Let's say you're working with an insurance company. A written oral communication, documentation skills, negotiation skills, conflict resolution skills, especially as a case manager, critical thinking, being able to be a good prioritizer. Okay. Case management, time consuming, labor intensive. We know that. Okay. And then a few things to know about care of the complex chronic illnesses in the community and some specific ones. So you can go through that. Okay. And then we just covered, I've really weaned down the week 9 notes into what we need to know for the exam. Okay. And then there's your 3 kinds of math questions. Calculate your single dose, calculate your IV dose over time, calculate mils per hour. Okay. Pretty simple and straightforward. Okay. Questions?
No, ma'am.
Yes, I got a question. Do you still have the homework grades on, or is it all taken off?
I took that off a couple of weeks ago. I sent an announcement about it. I took it off that Saturday that I posted exam 2 grades because I wanted you to not have to back out all the numbers and have so your grade right now is your straight up grade.
Okay. I got another question. Do you have any time after this class to talk to me for a few minutes?
Sure.
Or do you have an appointment? Okay.
No. Oh, actually,
That's
yeah.
okay.
No. Because we're gonna finish up here soon. I'll have a few minutes. I have to go to a at-risk meeting. But yes. And listen, don't start sending me emails about especially after this exam. What do I need to do? What do I need to pass my HESI? What score do I need to pass my HESI to pass the class? I'm not going to answer that. You all need a
Yeah, no, I
1200.
wasn't about to ask those kind of questions.
Okay, well, if that was a question you're going to ask, we don't have to meet. No, but we're all aiming for 1200. All right. I don't want you to be. I don't answer those kind of questions because then it lowers the bar. Right? Do the best you can. Okay.
I just need to make an appointment with you for my second exam. I never got to go over that, but
Yeah.
I just want to do that.
A lot of people do.
Oh.
Well, actually, this exam you guys did overall, everybody did quite well. If you didn't and you want to meet with me, let's set up a time because the exam's coming up next week.
Okay.
But yeah, don't start asking me what you need to pass the class. I'm going to tell you 1200. So try it, the reviews, I use the HESI prep, but also, I try and expand on some other topics that I can see, that are covered. So at least if you can't get to a review, listen to the recordings. Okay? Questions? I've really enjoyed the class. I really have. I hope you guys have, I hope I have presented it in ways that you understand and it's not too overwhelming. And essentially, it's an overview. This class is an overview of what happens in the community. A lot. A lot. Go ahead, Jayla, do you have a question? Or somebody had a question. Somebody was
I
starting.
have a question, but I want to ask you after the class. It's just a short question.
All right. All right.
Yep, mine is short too.
Okay.
Just want to schedule a time.
Yep.
I have one too as well.
Okay.
It's short.
No worries. No worries. Well, how about 10 minutes of the gift of time? How's
That'll
that?
work.
And I'll send you Professor Ford's recording, when I get myself organized here. Okay? So thank you. Thanks for everything. And then we'll see you. Just reach out if you need anything between now and exam week. Okay?
Thank you.
Thank you.
You're welcome. You're welcome.
Have a good weekend.
Yeah, you too.